Hey there. So, you've heard about SIADH, and maybe it's left you scratching your head a bit. I get it. It can be a tricky one. But don't worry, you are in exactly the right place. Today, we're going to completely demystify it. Think of it like a clinical puzzle. And by the end of this, you'll have all the pieces you need to solve it. All right, let's jump right in. So, let's set the scene. You've got a patient, right? Their blood work comes back, and their sodium is dangerously low, a condition we call hyponatremia. But here's the kicker. When you look at them, they show zero signs of dehydration. In fact, they seem, well, perfectly hydrated. So what on earth could be going on here? That is the central mystery of SIADH, and that's the question we're going to tackle. To solve this mystery, we have to find our prime suspect. And in this case, it's a tiny but incredibly powerful hormone that basically acts as the body's chief water manager. And that hormone is antidiuretic hormone, or ADH for short. Now just think of ADH as a gatekeeper for water in your kidneys. Normally, when your body is getting dehydrated, it releases ADH to tell the kidneys, hey, hold on to water, don't let it go out in the urine. It's a really crucial, life-saving mechanism that keeps us from dehydrating. Okay, so you can really see the difference here. On the left, that's what ADH is supposed to do. You're dehydrated, it kicks in, and it tells the kidneys to save water. Simple. But now look at the right. That's the problem in SIADH. The I is the key word here, inappropriate. The body is pumping out ADH even when it's totally hydrated. This forces the kidneys to hold on to way too much water. And what happens? Well, all that extra water dilutes the blood sodium, and at the same time, it makes the urine super concentrated. So here's the bottom line. SIADH isn't really a problem of losing sodium. It's a problem of gaining way too much water. The body is essentially waterlogged, and all that extra fluid dilutes the sodium that's already there, causing that hyponatremia we saw in our patient. Okay, so now that we know who the culprit is, let's look at the evidence. When we run lab tests on a patient with SIADH, we find this very specific set of clues that, honestly, at first glance, seem to totally contradict each other. Clue number 1 is the most obvious one: low sodium in the blood or the plasma. This is the hallmark of hyponatremia. It's the whole reason the patient is feeling unwell in the first place. And clue number 2 follows right from that. Because there's so much extra water diluting everything, the overall concentration of the blood, what we call its osmolality, is low. The blood is literally too watery. Now, this is where it starts to get weird. Clue number 3, the urine sodium is high. Now, wait a minute. If the body's sodium is low, why on earth would it be getting rid of more sodium in the urine? Well, it happens because as the body is trying to get rid of some of that excess water, sodium just gets flushed out right along with it. And for our final clue, the urine osmolality, its concentration, is high. This is the smoking gun, right here. Your blood is dilute, which should be a screaming signal to the kidneys to make lots of dilute urine to get rid of water. But because of that rogue ADH, the kidneys are doing the exact opposite. They're reabsorbing water and making the urine very, very concentrated. And this right here is the absolute core of it all. Seriously, if you take away just one thing about diagnosing SIADH, make it this paradox. You've got diluted blood, but concentrated urine. The two just don't seem to go together. When a clinician sees that combination, a huge light bulb should go off in their head, and SIADH should jump right to the top of the list. So how do we put all these clues together in a systematic way? Well, clinicians use a diagnostic flowchart. Kind of like this one. I know it looks complicated, but just think of it as a detective's roadmap. We're just going to follow the specific path that leads us straight to SIADH. First things first, right at the top, we check the serum osmolality. We have to confirm that it's actually low, less than 275. This tells us we're dealing with a true hyponatremia, where there's too much water, and not just some kind of lab error. Next, we follow that arrow down, and we assess the patient's fluid volume. Are they dehydrated, what we call hypovolemic, or are they overloaded with fluid, what we call hypervolemic? Well, in SIADH, the patient is usually right there in the middle, euvolemic. They have a normal fluid volume, which brings us to that central column in our flowchart. So, now that we're in the euvolemic category, the final step is to look at those urine tests. And what do we see? A urine sodium greater than 20 and a urine osmolarity greater than 100. These are our paradoxical clues from before, and on this flowchart, they point directly to a diagnosis of SIADH, and boom, case solved. So we've identified the condition, but we still haven't figured out why it's happening.
Diagnosing SIADH is really just the beginning. The next and maybe most important step is to find the underlying cause, the accomplices that are making the body produce all of this inappropriate ADH. And the list of potential culprits is incredibly broad. It can be triggered by disorders in the central nervous system, things like a head injury or an infection like meningitis. It can come from the lungs, pneumonia, or very famously small cell lung cancer. Other cancers can do it too, and a whole bunch of common drugs are known triggers as well. And this is exactly why finding SIADH is so important. As this image of a surgical suite suggests, it might be the very first sign of a really serious underlying problem. It could be a complication from a traumatic brain injury that a patient is already being treated for, or it could be the first clue that there's a hidden tumor somewhere in the body producing ADH all on its own. All right, time for the final act, closing the case. Once we've diagnosed SIADH and we're looking for the cause, how do we actually treat the patient and get their body's water balance back to normal? Well, the management follows a pretty clear, logical plan. First, you do no harm. Stop any drugs that could be causing it. Stop any low-salt IV fluids. Second, and this is the most important step, you restrict the patient's water intake. Third, for the long-term solution, you have to treat whatever underlying cause you find. And finally, if the sodium is dangerously low and the patient has symptoms, you might need to give a very concentrated salt solution called hypertonic saline very, very carefully. This quote really nails the treatment strategy. And let's be honest, it feels completely backward at first, doesn't it? The patient's sodium is low, so your first instinct is, let's just give them more sodium. But you have to remember, the real problem here isn't a lack of sodium. It's an excess of water. The body is waterlogged. So the best thing you can do, the most effective treatment, is to restrict their water intake. Just pull back on the fluids. That gives the kidneys a chance to finally get rid of all that extra water and let the sodium concentration come back to normal. So there you have it. We've cracked the case. We've seen that SIADH is this fascinating condition where the body's water manager just goes rogue, and it leads to that crazy paradox of dilute blood and concentrated urine. It really teaches us that a single abnormal lab value, like low sodium, can be a clue to a much, much bigger story involving the brain, the lungs, or even a hidden cancer. It really makes you think, doesn't it? What other single symptom or sign out there can act as a window into the complex workings of the entire body?